Thanks very much, Michael. Very interesting, a few things he said that I picked up on. If you're not fit for a haircut, in other words, if you're not fit for a GA, then you shouldn't be having a TAVI, and that's absolutely right. The ones that we've also had 2 that are arrested on induction, and we went ahead and did the TAVI and didn't get them off the table. So we've also learnt that, and I would agree with him with that. Unfortunately, we do ours all in the cath lab, but we do have them with surgeons and bypass machines and everything down there. So slightly different from Germany, where they have hybrid labs. We don't have any, and I don't know that many centres in the UK do. They've sort of adapted either a cath lab or something like that. But I'm going to talk about the role of the anaesthetist in the heart team, and the one thing I strongly disagree with Michael's talk was his heart team had a cardiologist interventional, a cardiologist non-interventional, and a surgeon. So I would say it's an incomplete team, and certainly according to NICE guidelines, the anaesthetist is part of the heart team and is involved in all the pre-assessment and selecting patients. So that's certainly a big difference from Germany. And as he pointed out, we're doing 10% of our patients under TAVI, where in Germany they're doing over a third. And that might be underrepresenting it. So it's a completely different spectrum. And this is the question that maybe we'll answer at the end of the day. Is this the future or just another fad? Is this that we were talking about 10 years ago in cardiology meetings where stenting was the future? Well, stenting has found its place as part of the management of coronary artery disease. So are we all going to have TAVIs when we need our aortic valves changed in 20, 30, 40 years' time? Or is TAVI going to be just a specific treatment for specific patients, or will it have died a death? So maybe we'll be able to answer that at the end of the day. Certainly at Papworth, which is very similar to many places in the UK, each patient is assessed by a multidisciplinary team with an anaesthetist as part of it. And NICE strongly enforces the rule that every patient must be passed by a cardiologist, surgeon and an anaesthetist before being put on the list. So in other words, NICE won't pay for it in the UK unless those 3 people have signed off the form. So at Papworth, we actually specifically sign off the form. We don't have any pre-funding. We have to send in a form to our regional funders for each patient. Now, I know that some areas in the UK are funding a certain number of TAVIs per year where you don't have to put in a form for each. So I know in Manchester you have a certain number, in Leicester there's a certain number, but certainly in Cambridgeshire and East Anglia we have to get funding for each individual patient, and NICE won't pay for it unless, our region won't pay for it unless they've been signed off by the anaesthetist. So we see every patient preoperatively, and I think that's the first service at Papworth where every patient, where the anaesthetist is part of the multidisciplinary team, goes to the MDT meetings and passes them off. And since we've started that, actually quite a few of the other services like PTE, adult congenital and transplant have now sort of putting the anaesthetist onto the multidisciplinary team. So maybe that role will increase as making sure that the right patients are going forward for surgery. And last week, NICE brought out new advice, which I'm sure you've seen, in that the previous advice was pretty much, as Mike pointed out, Euroscore more than 20, or turned down by 2 surgeons, or specific indications, valve-in-valve being one I've missed off. But the new advice has taken all that out, and they've said anyone who's high or moderate risk for surgery who's likely to survive a year. So we rang up our commissioners and said, OK, so we don't need to fill in this massive form. All we need to put is that they're at least moderate risk. And they said no, they're still going to go for the previous advice. They now don't accept that. They say that the new advice from NICE is not specific enough. So they're going with the old advice. So at the moment, when you apply for funding, it's still on the previous suggestion. But it may be that the whole game is going to change over the next year or so, and that all you've got to do is demonstrate that they're at moderate or high risk for surgery. So how do we assess for risk? Are they likely to survive the procedure? That's the key. If they're not likely to survive an anaesthetic or the procedure, then we shouldn't be doing a TAVI on them. And are they likely to be discharged from hospital? If they're just too sick for anything, then we shouldn't be doing a TAVI on them. And are they likely to survive a year? If they've got cancer, it's very difficult. If they've got prostate cancer that hasn't spread, then we do them because their 5-year survival is good. But if they've got lung cancer, clearly we shouldn't be doing them. And that likely to survive 1 year, as I say, is what NICE is now looking at. So often we do ask our colleagues, oncology specialists and so on, are they likely to survive a year? What's their 1 year and 5 year survival rate? And I think that's a very important part of the assessment process. So the 3 questions that we have to ask for each patient is, do they get a surgical AVR? Well, obviously in the UK we said 90% of our patients do. In Germany it's much lower. Are they best off with a transfemoral or another approach? And are they best served by having a general anaesthetic or local anaesthetic and sedation? In most centres in the UK, most patients have a general anaesthetic. Now, that is associated with cardiovascular depression and some prolonged drowsiness. So quite a few centres do it under sedation, where for transfemoral, obviously, not for transapical. And there's advantages and disadvantages to both. I know in Brighton they do a lot of transfemoral awake, whereas we do all our transfemoral ones asleep. And everybody puts forward the advantages and disadvantages for both. They would say that it's a very safe way of doing it under sedation, but there is some evidence that from Germany, from Bergman's group in Essen, where they did 100 patients under sedation, they converted 17%. Now that's a lot. That means that in 1 in 5, they're putting in an emergency anaesthetic. So they don't have their anaesthetist in the room. They're calling somebody to come down to sort out this patient who's under the drapes, not intubated, got a mask on, just had a bit of midazolam, or quite a lot of midazolam, and a lot of fentanyl, and they're either disorientated, which was 2 of them, or they've blown up the femoral, or they've ruptured the aorta or something, or they've had an arrhythmia and a cardiac arrest. And for those of us in the anaesthetist room, that is a nightmare time to give a GA. When they're under the drapes, you're trying to give them some drugs. What drugs can you give them when they're arrested? You're putting in a tube. You don't know where the access is. You don't know where the lines are. That's a nightmare situation. So we're scared of that situation. We don't like that emergency conversion to GA. So we put them all to sleep and wake them all up at the end. This is their data looking at comparing sedation and general anaesthetic. And they've showed that the statistically significant ones that I've highlighted in red, their post-operative ventilation rate was much higher in the general anaesthetic group, and their length of ICU stay and hospital stay was the same. So even though more patients were ventilated in the ICU in the GA group in their series, they still went home at the same time. And actually, when you go into their data in more detail, the GA patients, most of them had it at the beginning of their series of 150. So they moved over to sedation mostly in the second part. So actually maybe it's because they've sort of improved over the way they've done their first 150 cases rather than anything else. But despite their sort of improvement, their length of stay was the same in their 2 cohorts. And there's no survival benefit for GA versus sedation in this small group. So if you have a transapical, you've got to have a general anaesthetic. You can't really do a mini thoracotomy awake, although some centres in the UK have done this awake under an epidural. I wouldn't recommend it. They do get a lot of arrhythmias from the apical handling when you put the stitches in. And the big problem with the transapicals that we have is the post-operative analgesia. We do intercostal blocks. Quite a few centres are doing paravertebral blocks, and there's some good randomised studies going on between the 2 techniques for pain control and for post-op delirium. And post-op delirium is one of the biggest problems. If they're confused and agitated in the recovery, they can't really go to the ward, and a few patients that have been confused and delirious need to be reintubated. So good analgesia with some paravertebral block for the transapicals is probably the optimum technique. So sedation, we would say, should be provided by an anaesthetist. Now, obviously, that's more expensive. You're having an anaesthetist down at the list. But what you're not doing is calling someone in an emergency, which would usually be a junior person, into the cath lab in an emergency situation. So that means that you can't really do a single operator cardiologist setup. You would need an anaesthetist in the room for the beginning, and that would be more expensive. However, at least if we're in the room, we could give them some sort of more high-tech sedation procedure using propofol or Remi infusion. As you probably know, in the UK, only anaesthetists are licensed to give propofol. In fact, European-wide, the European Society of Anaesthetists has withdrawn the license for non-anaesthetists to give propofol because of a number of deaths with non-anaesthetists giving propofol. In fact, they have done in the US as well since the Michael Jackson incident, but that's now been withdrawn in Europe just from about 2 or 3 months ago. So the advantage in anaesthetists giving the sedation is we can use something a bit more high-tech as opposed to the cardiologists who will give a lot of midazolam and fentanyl, and then the patient may or may not get more agitated. The other thing that might like to think about is cerebral oximetry and optimizing cerebral perfusion during your TAVI procedure and deciding on what arterial pressure is enough. That's something we'll be talking about later today as well. And perhaps another useful monitor in the cath lab for these patients is BIS monitor, deciding whether the patient's deeply asleep or not, and also for helping you with depth of sedation. And that's a useful technique that we can use. At Papworth, we admit them to the recovery and then to the ward, so we don't send our patients to the ICU. And I think most places in the UK do send them to the ICU, and we save on quite a lot of resources by sending them straight to the ward and then home in 3 or 4 days. And we do that really by giving them good blocks for the transapicals and by having sort of monitored beds on the wards. And we make a cost saving from not admitting them to the ICU. It means that we can do more surgical patients and use those ICU beds on the same days. However, we do have about a 20% urgent admission to ICU from those patients. So they go to recovery, and then some of them don't do so well, so then they need to go as an urgent admission to the ICU. So there's some discussion at the moment, how many can we allow to be admitted as a sort of urgent rather than the planned admission before that becomes not sustainable. So it seems to be about 20% is the cut-off. If you can send 4 out of 5 to the ward, that's pretty good going. But if you're sending more than that to the ICU, then perhaps you should be sending them routinely. So that's under discussion at the moment. And with a fast-tracking setup that we've got, where we extubate them on the table and send them to the ward, our duration of intubation is about 2 hours for the TAVI, which is basically the length of the procedure, because we wake them up at the end. And then with a standard AVR, our length of intubation is about 12 hours. So that's the sort of the 4 or 5 hours of the procedure, and the 5 or 6 hours for them to warm up, for the nurse to wash them, change their drapes, go on a coffee break, come back and extubate them. So that's probably a bit long in that we're a bit slow in extubating them on the ICU, but still there's a big difference. And our intensive care unit stay for the TAVIs, bearing in mind that 4 out of 5 don't go to the unit, is significantly different. The TAVI patients, those that do go, their median stay is just under a day as opposed to 1.5 days for the surgical AVR. And then their length of stay is shorter, but that's not surprising. They've got smaller wounds, and even though they've got lots of comorbidities, they do tend to go home quicker. And again, that's statistically significant. So in summary, the granny test. If it was your grandma that came to you, or perhaps your mother or your wife, and they said, I'm going to have my aortic valve done, what do you want? What should I have? So we need to decide as clinicians, would we recommend your granny to have a TAVI or an AVR? So my granny's 85. She lives on her own. She's fit and well apart from some coronary disease which she's had stented, but she hasn't had a stenotomy. I'd still probably tell her to have a TAVI because she's 85. But even if she was 75, would I tell her to have a TAVI? Or 65 for my mother, would I tell her to have a TAVI? Probably not. And then would I tell my granny to have it under sedation or GA? Well, I would definitely tell her to have it under GA because I don't want that high conversion rate in an emergency. I think that's the dangerous thing. And then would I send her to the ward or the ICU? Well, probably send her to the ICU. But as I say, there's a significant sort of cost and resource implications of that. So what would you do for your granny? Thank you.
Thank you very much. Any questions for Andy? Can I just ask, as a unit that does do it under sedation, we do actually have the anaesthetist in, and you can actually make the anaesthetist cost effective. You get them to put the pacing wire in and other things. So, you know, it does help because you don't have the pacing, particularly after core valves left in the groin. You can get them up and about a lot easier. So they are useful in cath labs as well.
I think the question is how much of evidence we have that sedation makes a difference in general anesthesia. There is no evidence, as you nicely described. And how much of the drive of the sedation option is coming out of the fact that it makes cardiologists more independent on doing the procedures. Right? In your case, you describe it's done with the heart team and everyone is there, but there are a lot of centers where it's differently handled. And Michael said, demonstrated already, that there are centers in Germany where cardiologists do these kind of procedures without even having cardiac surgery on their side. Right?
Or anaesthetists.
So I think it is, as long as there is no proper evidence that sedation is having some kind of benefits, where's the point in going there? And I think in preserving the right framework and the right infrastructure and the right kind of team for this kind of procedure, I think it's appropriate to advocate general anesthesia option for these patients.
But unfortunately, despite anaesthesia being around for over 100 years, there's no evidence that anaesthesia is safer than sedation. No one has yet developed a randomized controlled trial showing that 100 hernias under sedation versus 100 hernias under GA are safer or better. There's no evidence that one is better than the other. So that's the crux of the whole thing. So, you know, you can use the argument both ways. We would say a GA is safer because when you get into trouble, it's much easier to get yourself out of there. But those who do sedation all the time say it's better because they wake up quicker. In fact, there's no evidence that they do wake up quicker. And if you look at the studies, they don't go home any quicker. They might be a bit more awake for the first hour afterwards, but they still go home on the same day.
No question. But that's the reason why a responsible TAVI community can have some other views in mind as well, to make it a safe kind of approach and something which has some kind of perspective for the future.
Yes, I agree. The whole team should include everybody.
Okay. I think we're going to move on